Hey all, welcome back to the Real Life Pharmacology podcast. I'm your host, pharmacist Eric Christensen. Thank you so much for listening today. Go check out reallifepharmacology.com. We've got a free 31-page PDF on the top 200 drugs. It's a great study guide, great refresher. Simply an email is all it'll take to get access to that. We also get you updates when we've got other content available as well. So please go take advantage of that at reallifepharmacology.com. All right, the drug of the day today is Insulin Aspart. Brand names of this medication, Novolog is the one I've heard the most. Fiasp is also a slightly newer variation on that medication, Insulin Aspart, as well. So these medications are both rapid-acting insulins. Just want to mention briefly the difference between Fiasp and Novolog. So Fiasp works slightly quicker. It has a slightly quicker onset. And the reason for that is it's essentially tied up to vitamin B3. Your vitamin B3 is added to the formulation, and that helps aid the quickness of the absorption. So again, very, very slight difference, but it does lead to an important point that these two medications are not considered interchangeable. So definitely if you're switching from one to the other, you should pay attention. You should educate your patients that we do have a little bit quicker onset, and that may alter the way the medication is administered a little bit as well, as far as the timing with meals and things of that nature. So with that said, Insulin Aspart used in type 1 diabetes, type 2 diabetes, diabetic ketoacidosis. It can be used potentially in generally more mild to moderate cases. Severe cases, we're probably using regular IV insulin, which has been a little bit more studied and a little bit more background, I guess, in that area there. Mechanistically, how does insulin work? I'm not going to go through all the numerous mechanisms of action. Probably the one that you'll hear the most in how it reduces blood sugar is its action in the liver. So the liver basically produces glycogen, which is basically a storage form of glucose. Insulin promotes that activity or stimulates that activity of building up those glycogen stores and storing glucose. So the liver naturally needs more glucose to do that, and it takes it out of the bloodstream. Hence, it reduces blood sugar. All right, let's talk a little bit about administration. So first and foremost, a few common things that should be noted. Solution is generally going to be clear or colorless. If it's not, that is an issue and potentially could be noted as, the product's gone bad or there's something wrong with it. So again, clear, colorless. Avoid giving the administration cold out of the fridge. Subcutaneous is the standard route of administration. Most patients use the abdomen. Thigh and upper arms are appropriate locations there as well. With that administration and also tying that in with the kinetics, I mentioned Fiasp being a little bit quicker. That's recommended to be given at the beginning of the meal or within 20 minutes of starting that meal. Novolog is recommended to be given 5 to 10 minutes before a meal. So that's the general recommendations. Now, I've certainly had patients do it a variety of different ways, but if we start straying a little bit too far in those situations, naturally that's going to kind of impact the kinetics and when the spike in that insulin and when the action takes place. So really got to pay attention to that, discuss that with patients, making sure that we're having some consistency there. And looking at those blood sugars and seeing how they're responding. Injection sites, I did want to mention that as well. So within the abdomen, it is recommended to kind of move those spots around. You don't want to use the same exact location in the abdomen all the time. That's to avoid lipoatrophy. So again, remember to kind of rotate those sites within the site that the patient is using there. I'm not going to go into the details of storage and beyond use dating. However, if you're interested in that, I've got an absolutely free PDF. Doesn't cost you anything. Google search MedEd 101 insulin storage PDF, and it should pull right in for you, and you can get that free PDF, which goes through all the different insulins and storage and things of that nature. So definitely go check that out. Again, insulin storage, MedEd 101 PDF. Punch that into Google, and you should find it, no problem there. All right, let's get into adverse drug reactions. So as you can imagine, hypoglycemia is the big risk with insulin therapy in general, and of course with insulin aspart as well. I've seen numerous instances where patients have kind of changed their diet or their eating patterns, or maybe they're not feeling well, or we've made a mistake in the dosing and given too much. All this can potentially lead to the increased risk of hypoglycemia. Insulin aspart is in the Beers criteria for potentially inappropriate medications in the elderly, but it's in relation to specific situations. So the major situation that we should generally avoid using insulin aspart is in sliding scale insulin. So that's basically giving insulin based upon the blood sugar at the time. So it increases the risk for hypoglycemia. And in addition to that, we really don't have much evidence that shows that it really helps hyperglycemia and A1C management really at all. So again, don't use it for sliding scale insulin if at all possible. I certainly have seen it. If it is used, hopefully it's for a very, very short amount of time when we can figure out their schedules and schedule that insulin appropriately. Also avoid monotherapy with rapid acting subcutaneous insulin. Okay, that is also another recommendation with that Beers criteria kind of warning or precaution. Other adverse effects, weight gain. So hypoglycemia and weight gain, those are the two biggies with insulin therapy. Injection site reaction can certainly happen. Hypokalemia, so low potassium. If you remember, in hyperkalemia, insulin is actually a treatment. Now, usually it's more so in the hospital setting, and we're using IV insulin. But insulin itself, all insulins can cause the intracellular shift of potassium, which brings it out of the blood and ultimately reduces that serum potassium level. So, again, on a chronic basis, it's generally not something I'm crazy concerned about. But if you have, maybe a patient that used an inappropriately high dose, or there was an error or something, that could definitely increase that risk significantly if it was a significant amounts of insulin. All right, monitoring parameters, definitely wanted to mention that. A1C, blood sugars, weight, kind of common monitoring parameters there. Just a reminder of general goals, definitely something that could come up on board exams throughout your career. Currently with ADA, we're looking at A1C of less than 7 for most adults. Pre-prandial or before meals or fasting, we're usually looking in the 80 to 130 range as a target goal. And again, this can vary depending upon the patient. We like to try to set individualized goals, but that's kind of the general range. Postprandial, we generally want to target less than 180. In pregnancy, I wanted to mention that as well. It's kind of a unique case. Generally less than 95 is recommended by guidelines for fasting blood sugar, and less than 140 at 1 hour postprandial is ideal or recommended in pregnancy. Again, probably going to have some individualized goals there depending upon the patient, depending upon where they're at and where they've been coming and going, but those are some good reminders from the guidelines there. Last but not least, I wanted to mention insulin's a high alert medication. Okay, it's a high risk medication. I've seen numerous issues, numerous errors where we're off on the dose, and whether it be a handwriting issue or an order entry issue, it can easily happen where a patient gets 20 units when they should have got 2 units or 30 units instead of 3. So those tenfold errors can definitely happen with insulin. I've seen it. It's definitely unfortunate. It's definitely scary if you're the one who administered it, or if you wrote for the dose, or whatever the case may be. So really, really pay attention to those dosages. And if something doesn't make sense, be sure you ask, double, triple check, making sure that what we're doing is the right thing for the patient. All right, let's take a quick break from our sponsor, and I'll wrap up with drug interactions. If you're in the market for any Pharmacist Board certification study material like BCPS, NAPLEX, ambulatory care, geriatrics, MTM, go check out meded101.com/store, S-T-O-R-E. We've got a great list of resources there. In addition to those Pharmacist Board certification study materials, we've got books on various topics, whether you're looking for a little entertainment with education, with crossword puzzle books, if you're looking for case studies, if you're looking for drug interactions, if you're looking for food medication interactions, we've got all sorts of different options, and all those links you can find at meded101.com/store. All right, let's wrap up with drug interactions. So first and foremost, I'm looking out for hypoglycemia. So anytime we add another diabetes type agent, we've got to pay attention for that increased risk of hypoglycemia. Beta blockers, I wanted to mention specifically, they can mask some of the signs and symptoms of hypoglycemia. Weight gain, so that can certainly be an additive issue. I think of pioglitazone, for example, for treating somebody with type 2 diabetes and they're on pioglitazone and insulin. That could definitely increase the risk for weight gain. And then I do think about antibiotics. Some antibiotics specifically, quinolones, have been associated with causing some hypoglycemia in patients taking insulin. But in general, when I see new antibiotics in a patient taking insulin therapy, I worry about hypoglycemia and making sure patients are staying on track with their blood sugar monitoring. The reason being, when patients are getting antibiotics, they generally don't feel that well. And so their diet has changed, their body is under varying amounts of stress. So really, really important to monitor those blood sugars when we're starting new medications and a patient has an infection going on there. And then last but not least, wanted to mention corticosteroids. They can cause some significant hyperglycemia and kind of counteract what we're trying to do with the insulin. And to a lesser extent, thiazide diuretics have been shown to cause some hyperglycemia as well. But in my experience, definitely not near as significant as corticosteroids like prednisone. All right, well, that wraps up the podcast for today. Do me a huge favor, leave a rating review on iTunes or wherever you're listening. Share us with colleagues, listserv, pharmacy students, med students, nursing students. Definitely help spread the word on pharmacology education and share this podcast with them. I greatly appreciate it. If you got comments, questions, mededucation101@gmail.com, or you can track me down on LinkedIn as well. Hopefully you found some good practice pearls, or I re-jogged your memory of some things maybe you had forgotten. And I hope you have a great rest of your day.